sir.
Okay.
Yeah, now it's okay.
And my slides are also visible, na?
Now slide is also visible, sir. You are also
Okay.
visible, slide is also visible.
Okay, thank you. So, good afternoon, everyone. We are again on Saturday afternoon. We are again on this platform for a discussion on protocols in IVF. Now, we know that in IVF or in vitro fertilization, the target is to achieve a good quality embryo, that is an euploid embryo. But to get one or two good quality embryos, most of the time we need more follicles. As all of us know, in a normal menstrual cycle, we can get a single follicle. So we need to stimulate the ovaries. That is a controlled ovarian hyperstimulation. But there have been some challenges before us as a clinician when you go for a controlled ovarian stimulation for IVF. So this one challenge was an LH surge, premature LH surge. So if you look at history of IVF, the first reported IVF baby was in a natural cycle. By that time also people were working on stimulated cycle, that is stimulating the ovaries, or natural cycle, both. But initially there was not much success because of this premature LH surge and all these problems. Later on we got generalized agonist molecule, and this agonist molecule was the cornerstone of IVF to prevent this premature LH surge in the initial years. After 99 or 2000 we got antagonist molecule also. Initially there was a bit of apprehension amongst the clinicians to replace traditional agonist cycles with antagonist cycles, but there have been contradicting reports of which protocol will be better, agonist or antagonist. But if you see, for last 10 years or so, antagonist cycle is gradually replacing agonist protocol for IVF stimulations. So in this lecture we'll try to go through different type of protocols, what are the advantages, disadvantages, and which group of patient will be suitable for which kind of protocols. So our learning objectives will be criteria for IVF protocol selection, generate agonist long protocol versus antagonist protocol, and then recommendations for ovarian stimulations. Does hormone pretreatment improve efficacy and safety to ovarian stimulation? Which LH suppression regime is preferable? Is the type of stimulation drug associated with efficacy and safety? What is the safety and efficacy of non-conventional start stimulation compared to standard early follicular phase stimulation? What is the preferred drug for triggering of final oocyte maturation in terms of efficacy and safety in the overall IVF or ICSI population? What is the efficacy and safety of luteal support protocols? So first I come to the criteria for IVF protocol selection. First of thing I can tell you that any protocol can be used for any patient. Basically, means you can use agonist protocol for any kind of patient, you can use antagonist for any kind of patients. But certain patients are better off with a certain protocol. So if I look at patient classes according to ovarian responses, that means the likely responses, when you count according to AFC count, we know that when AFC count is less than 5, the patient is most likely to be a poor responder. And in this kind of patients, if the patient is likely to be a poor responder, both antagonist and agonist protocol are equally recommended. When patient is a normal responder, that is AFC count between 5 to 15, then antagonist protocol has certain advantages over agonist protocol. Again, if the patient is a high responder, that is patient is high likely to develop OHSS after stimulation, that is an AFC count more than 15 or 20, this group of patients are definitely better off with generalized antagonist protocol And I can say that generic antagonist protocol are actually protocol of choice for high responders. So what are the, besides this ovarian antral follicle count or expected response, what are the other factors to choose an IVF protocol? Outcomes of previous IVF cycle. So patient came to us. Here we have to remember one thing, that some of the patients in previous cycle may be poor responder who were actually not diminished ovarian reserve. So this kind of patient, we may need to change the protocol to get a better oocyte response. So outcome of previous IVF cycle, and in that cycle what was response to certain medications, that will guide us, or that will have an effect on our decision regarding that protocol selection. Presence of other comorbid conditions such as PCOS, age of the female partner, risk of developing OHSS, type of infertility and underlying cause. I can give you one example. Suppose a patient is suffering from endometriosis. You are going for a stimulation. And in endometriosis, in some of the groups, agonist protocol, that is a protocol with down regulation, may be a bit more effective than antagonist protocol. So type of infertility can be a factor in deciding IVF protocols. Now, these are the two traditional protocols, generic agonist and generic antagonist. Now, what are these two basic protocols? Before I go into comparison between the two, in 2-3 minutes I'll give you some outline of how these protocols work. In generic agonist, we use an agonist molecule like leuprolide or a triptorelin or a buserelin for pituitary suppression. And this suppression, pituitary suppression, actually prevents premature LH surge, so that we can get more follicles, more oocytes, and more embryos. So this agonist can be used by 3 protocols, I can say. In long protocol, you start the suppression from day 21 of the previous cycle, and after say 10 days or so of agonist, you get pituitary down regulation, and then you start stimulation. When follicles are mature enough, you think they are ready for OPU, you give a trigger. Here the trigger will be mostly human chorionic gonadotropin, and you go for ovum pickup. This is a long protocol, and that has been the classical protocol, has been used for quite a long time in IVF circuit. Now, another protocol is a short protocol, where you start generic agonist from day 2 of cycle. If you start from day 2 of cycle, there will be initial, along with gonadotropins, FSH or combination of FSH, HMG or HMG. That discussion will come later. But you start from day 2, you start agonist along with gonadotropins. And when you use agonist in standard dose, that is 1 mg, suppose leupride 1 mg subcut per day, you will get initial flare-up reaction. That will help us to release that endogenous gonadotropin. You can get better stimulation or better follicular response. And after 3, 4, 5 days, there will be that pituitary down regulation. So you continue agonist up to these follicles. When at least 3 follicles are more than 17 millimeter, you can go for a pickup with HCG trigger. That's a short protocol. Or there can be ultra short or microdose flare protocol, where from day 1 or day 2 of cycle, you can start generic agonist with a dose of 40 to 50 microgram twice a day, and after start of 48 hours of microdose of generic agonist, you start gonadotropin stimulation, and again when follicle reaches a certain size, you go for ovum pickup. So these are 3 generic agonist protocols which are commonly available: long, short, and ultra short. And in generic antagonist protocol, you start stimulation with gonadotropin, either FSH or HMG or combination, from day 2 or day 3 of menstrual cycle. And after later on, you start generic antagonist molecule, that is ceftolix or ganirelix, for pituitary down regulation to prevent premature LH surge. Now, this antagonist can be used in 2 sets of protocol: flexible or fixed. In a fixed generic antagonist protocol, usually we start stimulation from day 2 to day 3 of cycle. You start gonadotropin. On day 6 of cycle, irrespective of ovarian response, you start your antagonist. That is ceftrolix 0.25 subcut daily or a 3 mg depot preparation. This depot preparation will be active for 4 days. After 4 days, you have to repeat the depot preparation again. One advantage is antagonist is more user friendly. Patient don't need to pay more visits. But as you are not monitoring it, there can be poor follicular response also in this fixed protocol. In flexible protocol, you give stimulation for initial 3 to 4 days, that is you start on day 2 or day 3, and you wait till the dominant follicle reaches at least 12 millimeter. Some literature say 14 millimeter. Some author says 12 millimeter. So when the dominant follicle reaches more than 12 millimeter or 14 millimeter, and you get other follicles, at least more than 3 follicles which has been more than 10 millimeter, you know there have been enough follicular recruitment, you start antagonist molecule. You start either a depot preparation or a daily preparation. But that's a flexible preparation. Advantage with flexible preparation, depending on patient's response, you can actually, it's not a tailor-made protocol. You can actually adjust protocol according to patient's response. That's the advantage of flexible. So there are two kinds of protocol in generic antagonist. So if you look at, these are the basic of this agonist and antagonist protocol. Now let us see the difference between them. So I have mentioned this comparative summary. I have already mentioned that in a long agonist protocol, you start this suppression or down regulation from day 21 of the previous cycle with generic agonist, and on day 1 of this withdrawal bleeding or day 2 of withdrawal bleeding, you start with gonadotropin. And when you decide that okay, you are ready for an oocyte retrieval, use HCG as a trigger. In an antagonist protocol, you see you start with gonadotropin. Depending on flexible or fixed protocol, you start ceftrolix later on. And here in antagonist protocol, the advantage is you can use as a trigger HCG is an option. But along with that, in antagonist protocol, you can use agonist as a trigger, particularly in cases where there is a more chance of OHSS. So antagonist protocol has this advantage to prevent OHSS. So if you use it in a hyper responder, if you think okay, patient has developed OHSS, to prevent severe or critical OHSS, you can go for an agonist trigger in antagonist protocol. That is the advantage of antagonist protocol. But in agonist protocol, remember HCG will always be the trigger. And if you remember the pathophysiology of OHSS, you know this trigger is the culprit mostly. HCG trigger is the culprit for ascites formation, and that is the formation of third space fluid collection leading to severe OHSS. That is mostly after HCG trigger. So if you can avoid HCG trigger, most of the number, more than 99% of OHSS, severe OHSS is preventable in antagonist protocol. That is the advantage of antagonist protocol. And there is another protocol of minimal stimulation where you can use combination of an oral letrozole or clomiphene citrate along with gonadotropin, and you can use antagonist when lead follicle is at least 14 millimeter size. You can start your antagonist. Now coming to these recommendations. Does hormone pre-treatment improve efficacy and safety of ovarian stimulation? Pre-treatment with estrogen before ovarian stimulation using the generic antagonist protocol is probably not recommended. There have been people in poor responders, they thought if you start estrogen from day 20 on a previous cycle, it may improve the ovarian stimulation, but there has not been a definite evidence regarding that. Pre-treatment with progesterone before ovarian stimulation is probably not recommended. Estrogen or progesterone is widely used for scheduling purposes. It is acceptable for this use. Oral pills, combined oral contraceptive pill pre-treatment is not recommended due to reduced efficacy, need for more doses of gonadotropin. So otherwise, if you are doing batch IVF, then it's okay to use OC pills. Otherwise, in other patients, we don't prefer batch approach, or we don't prefer a pre-treatment with oral contraceptive pills. Generic antagonist pre-treatment before ovarian stimulation in a delayed start gonadotropin protocol is probably not recommended. Now, which LH suppression regime is preferable? I have told that The biggest enemy of an IVF specialist is premature release surge. Remember, they will ruin your cycle. So if generic agonists are used, the long generic agonist protocol is probably recommended over the short or ultra short generic agonist protocol, because there is always an apprehension regarding the pituitary down regulation or prevention of early surge. I have already mentioned there are three kinds of protocols you can use for an agonist. That is long or classic protocol, short and ultra short. So the long protocol may be probably recommended over that, but one disadvantage of this long protocol is time. You need almost 6 weeks to complete your cycle. So a lot of time it's difficult for the center and for the patient also. So it's not a very clinician friendly or a patient friendly approach to have a long protocol. Now the generic antagonist protocol is recommended over the generic agonist protocol, given the comparable efficacy in respect to live birth rate and higher safety in general IVF RICSI population. The use of progestin for LH peak suppression is probably not recommended. If applied, progestin can only be used in the concept of non-transfer cycle. That is the third one. You know that the recent concept is there for IVF protocol, that is a PPOS, progesterone primed ovarian stimulation. There have been lots of papers on that, where people are using progesterone from either day 2 or day 3 of cycle along with gonadotropin, or from day 5 or day 6 of cycle along with gonadotropin stimulation, because you know if you use progesterone on a daily basis, they will prevent ovulation by preventing premature early surge. So you need less number of injection. The advantage of using progesterone is you can use a norethistérone or a dydrogesterone for prevention of LH surge. And the advantage, these are all oral preparations. You don't need to use antagonist injections. But problem happen with, you can never go for a fresh embryo transfer because your endometrium will not be prepared. So you have to go for a segmental approach. That is, you have to do the pickup, do the embryo, you have to freeze your embryos, freeze all embryos, and do the transfer later in another cycle. That is called a segmental approach. Sometimes it may not be practically possible, and you have to have a very good cryopreservation facility if you want to use an PPOS. But it is more preferable for a donor oocyte program, because in donor oocyte program you don't need to transfer the embryos, so you can use progesterone for to prevent premature release surge in place of antagonist. But again, you have to remember, these are new protocols. Some studies are coming up. There has not been much of comparative study or randomized controlled trials regarding this. So unless we get this, this is our individual choice to go for a PPOS. Is the type of stimulation drug associated with efficacy and safety? The use of recombinant FSH and HMG for ovarian stimulation is equally recommended. The use of recombinant FSH and purified FSH for strong ovarian stimulation in generic agonist protocol is equally recommended. The use of either recombinant FSH or highly purified FSH for ovarian stimulation in generic agonist protocol is equally recommended. The use of highly purified FSH and HMG for ovarian stimulation in agonist protocols are equally recommended. Is the type of stimulation drug associated with efficacy and safety? Again, that has been a question. The use of recombinant LH along with recombinant FSH for ovarian stimulation is probably not routinely recommended over HMG in generic agonist protocols with regards to safety. Letrozole is probably not recommended as a substitute for gonadotropin in poor responders, although some may disagree with that, because some of the patients, some of the authors believe that you can use letrozole for a poor responder, because in any case you are going to get less number of oocytes. So what's the point in using such a huge dose of gonadotropin where you are not getting excess number of oocytes or increased number of oocytes? The use of long-acting and daily RFSH is equally recommended in generic antagonist cycles for normal responders. But advantage of long-acting FSH is like corifolitripin alpha is they can be given over 6 or 7 days. So patient don't need to take a daily injections. That's a patient-friendly approach. There is no evidence available to recommend the substitution of FSH by clomiphene citrate in ovarian stimulation. What is the safety and efficacy of non-conventional start stimulation compared to standard early follicular phase stimulation? Random start ovarian stimulation is probably not recommended for general IVF or ICSI population. Luteal phase stimulation could be used in non-transfer cycles. Late luteal phase start of the gonadotropins is probably not recommended for poor responder, and early luteal phase start is probably not recommended for normal and poor responder. Double stimulation in poor responder should only be used in the context of clinical research or for the urgent fertility preservation cycle. You know, there has been a lot of topic on discussion on this double stimulation or duo stim, where the concept has been that follicles are recruited in batches. So first, in a follicular phase, in a cycle day 2 or day 3, you start an antagonist cycle, you give stimulation, you get some number of oocytes, you feel that is not adequate. So after you do the pickup, freeze all the embryos. After 72 or 96 hours, you start another round of stimulation in the same menstrual cycle. Again, I'm telling you, these are the new protocols. So some author will claim, of course, they had more better number of oocytes, more number of embryos. So there is no routine recommendation on that. Mostly on the research purpose or research articles are there on that dual stimulation. In some of the poor responders or for embryo pooling, we can go for double stimulation. But again, these are not routine protocols. You have to understand it. Preferred drug for triggering of final oocyte maturation in terms of efficacy and safety. The use of recombinant HCG and urinary HCG is equally recommended for triggering final oocyte maturation during ovarian stimulation protocols. A reduced dose of 5,000 international unit of urinary HCG for final oocyte maturation is probably recommended over a 10,000 dose in agonist protocol, as it improves safety in a sense of prevention of OHSS. Because you know, in agonist protocol, you have no choice. You have to go for an HCG trigger. So if the patient is already is a likelihood candidate for severe OHSS, you can use a 5,000 instead of 10,000 dose, because 5,000 HCG will be cleared from the circulation in 4 or 5 days, whereas 10,000 dose will take 8 to 10 days to get clear. So there is more external stimulation for this OHSS. So 5,000 dose will be better in terms of safety. It is not recommended to administer RLH for triggering final oocyte maturation. Again, RLH still at research level, there are some papers on using of RLH for triggering final oocyte maturation. The use of generic agonist for final oocyte maturation with conventional luteal support and fresh transfer is not recommended in general IVF population. As I mentioned already, in antagonist protocol, where you think the patient is already an hyper responder, likelihood candidate for OHSS, you can use a generic agonist like lupride 1.5 or a triptorelin 0.1 or 0.2 mg subcut as a trigger. But if you use them as a trigger, there will be initial flare up, initial LH release, LH surge. But after 48 or 72 hours, there will be a down regulation of pituitary down regulation that will affect the luteal phase. So with a conventional luteal support, that may not be adequate. So you can get good embryos, but there is less chance of implantation. So if you are using an agonist trigger, better to go for a segmental approach, that is you freeze all embryos, go for embryo transfer in a later cycle if it is permissible or if it is feasible. But for that, you have to understand there you need two things. One is patient's compliance, patient can be available for another cycle or not. Second thing is you need to have a high quality cryopreservation facilities. The use of generic agonist for final oocyte maturation, luteal support with LH activity and phase transfer is probably not recommended for the predicted normal responder. If the generic agonist trigger with triptorelin is applied, doses ranging from 0.1 to 0.4 mg can be chosen. My preference is 0.1 to 0.2 mg subcut for a triptorelin trigger. The addition of a generic agonist to HCG as a dual trigger or for final oocyte maturation is probably not recommended for predicted normal responders. What is the efficacy and safety of luteal phase support protocols? Progesterone is recommended for LPS after any agonist or antagonist protocol. So any of the routes can be used for progesterone, IM, IV, oral or subcutaneous. Starting of progesterone for LPS should be in the window between the evening of oocyte retrieval and day 3 of post-oocyte retrieval. Normally we start our luteal phase support with progesterone on the evening of oocyte retrieval day. Progesterone for LPS should be administered at least till pregnancy test. Dydrogesterone is probably recommended for luteal phase support. The addition of estradiol to progesterone for LPS is probably not recommended, although it has been a common practice to add estradiol for luteal phase support in IVF cycles. If In HCG triggered ovarian stimulation cycles, HCG as LPS in standard dose of 1500 international unit is probably not recommended. So, a generic agonist bolus in addition to progesterone for LPS in HCG triggered cycle has been recommended by a lot of authors. But again, if you use generic agonist, there is chance of this down regulation that can hamper your luteal phase. Repeated generic agonist injections alone or in addition to progesterone for LPS in only HCG triggered cycles. Addition of LH to progesterone for LPS, this has been proposals, but again, these are only to be used in clinical trial, not for day-to-day practice. Again, I am telling you, the day-to-day practice, we use a progesterone along with estrogen for luteal phase support. To summarize, high and normal responder antagonist protocol is normally the first line choice for us nowadays. For poor responder, both antagonist and agonist protocol can be used. Pre-treatment with estrogen or progesterone may be used only to time the cycles and not for the safety or efficacy. That is, if you are batch cycles, then you can pre-treatment with an hormone. Generic antagonist protocol is most preferred nowadays. If agonists are used, long as agonist protocol is preferred over others. But one of the agonist protocol, that is microdose flare protocol, is preferred by a lot of clinicians in poor responder or diminished ovarian reserve. That random start ovarian stimulation is probably not recommended for general or routine IVF populations, and progesterone is recommended for luteal phase support after an IVF or ICSI cycle until the pregnancy test. No doubt about it, progesterone is beneficial beyond doubt. So thanks all of you. Now, if you have any question.
Sir, thanks for your valuable insight on IVF protocols. And thanks viewers for your lesson sharing. May I request if you have any question, then you can ask with doctor. Is there any questions? You can unmute yourself and ask directly to the doctors. From viewers, is there any questions? Sir, I think...
okay, we can close our session, I think.
Yeah, no question is there. Thank you,
Okay.
sir. Thank you.
Thank you.
Take care, sir. Okay, bye.